Good afternoon and welcome to Psychiatry Grand Rounds. There's no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for our presenter today, please hold until the Q&A segment and we'll ask the questions then. A link to the event evaluation will be shared at the end of the program. And if you're viewing virtually and have a question, go ahead and put that in the Q&A section and we'll be sure to ask for you. So I'll have Dr. Samuel Dotson, Program Director of Northeast Georgia Medical Center Psychiatry Residency Program, introduce our guest speaker today.
Thanks, Jennifer. So I wanted to start by saying I do not typically wear a t-shirt to work. It's Mental Health Awareness Week month. And I wanted to say thank you to everybody who came out this morning to United Way for our annual Walk in Green down Green Street. It was great to see people there. Today we have the pleasure of hearing from Dr. Luccarelli, somebody who I actually graduated with at Massachusetts General, and it's been great to kind of follow his career and his work on both Catatonia and ECT, so we're very excited for this talk today. Dr. Luccarelli completed a doctorate in organic chemistry at the University of Oxford in the United Kingdom as a Marshall Scholar prior to matriculating at Harvard Medical School. He then completed his residency in psychiatry with the Child and Adolescent Psychiatry Fellowship at the combined Massachusetts General and McLean Hospital Psychiatry Training Program. Since completing his training, he has worked as an attending psychiatrist at Massachusetts General Hospital, where he currently serves as the Director of Pediatric Neurotherapeutics and is an assistant professor of psychiatry at Harvard Medical School. His research interests focus on the epidemiology of psychiatric disorders, as well as optimal treatment strategies, including evidence-based treatments and pharmacology. He's received funding from numerous government and institutional sources, including the NIMH, National Institutes of Mental Health, the Foundation for Prader-Willi Research, and ACAP, the American Academy of Child and Adolescent Psychiatry. He also has received funding from the Rappaport Foundation, and he's the author of more than 100 peer-reviewed publications and book chapters. And I'm very excited to hear him speak for us today. Please join me in welcoming Dr. Luccarelli.
Thank you so much, Dr. Dotson, for inviting me here today and to the whole team that we have. So my goal today is to present on some specific data about ECT and catatonia that's been coming out of my research group over the last few years, but also to speak more generally about the concept of real-world evidence as an alternative way of thinking about data in the clinical context. So just to begin with disclosures, I have consulting fees from a couple of pharmaceutical companies unrelated to the content of this talk. I will be discussing off-label uses of electroconvulsive therapy devices, and we'll talk specifically about what they are in fact FDA approved for. And then I will be discussing off-label medication treatments of catatonia, and that's because there are no FDA approved medications for the condition, so everything is off-label for catatonia itself. So again, objectives are to talk about real-world evidence as a source of clinical knowledge, one that's coming into increasing use, to describe effectiveness of ECT, particularly in clinical populations, and then to talk about catatonia, both its diagnosis and particularly its treatment in pediatric and neurodivergent populations who've received less research attention in catatonia in general. So starting with real-world knowledge. I think one of the key questions we always have as clinicians is how do we know any of the knowledge that we know? So we have all sorts of data that informs clinical practice. I think most of us in psychiatry especially go off of our personal experience, but we know that there's real limitations to that as well. Think about, do we think smoking is correlated with lung cancer? Well, when 90% of your patients smoke, you're not really going to see that correlation one-to-one because it's present as a risk factor for so many of the people in front of you. We could have expert consensus. Instead of one person's anecdotes, we can bring a group of us together to talk about anecdotes, but that can lead to some pretty clearly clinically wrong answers. From an oncology perspective, radical mastectomies, chopping out as much tissue as you possibly can, everyone agreed was the right thing to do, but when the trials were actually run, was ultimately harmful to patients. We can have observational data, so looking at cohorts and describing descriptively what's going on in clinical practice, but how are we getting that cohort? What does it look like? Is it representative of others? And likewise, what we usually put at the highest level of evidence-based randomized controlled trials. But anyone who's been part of an RCT knows the RCT population is pretty different from what we often have in routine clinical practice. Our inclusion and exclusion criteria may mean that a clinical trial doesn't reflect the actual patients that we approach. So the theory and sort of the idea behind all the work that I'm going to present today and the aspiration is that the idea of if we use our brains and we think and our experience and what we see, and then we add some data, that is probably better than just using our brains alone, that we should try to actually get as much evidence as we can possibly gather from as many sources as possible, and then do some thinking informed by more patients than any one doctor will ever be able to treat. And the potential for this really comes out of the really increasing rise of electronic medical records over about the last 15 years. So I know all of my own pediatric records exist on paper somewhere, maybe, if it hasn't burned down or gotten lost to the sands of time. But now almost every piece of information that happens to all of our patients exists in the electronic health record. And since about 2014, virtually everyone has had an electronic health record, which means that for the first time ever, we're gathering in machine-readable, systematic ways more pieces of information, more data than we've ever had before in a clinical context. So specifically within the Mass General Brigham system where I practice, I've got to update this slide over the last 5 years, but even as of 2020, so sort of the beginning of COVID when we made this, we had 3.5 billion structured facts. Now, what is a structured fact? Really any piece of information you could think about in the HR. So a height, a weight, a blood pressure, a temperature measurement. And as a result of this, we just have a lot of pieces of data that we can apply in more comprehensive ways, more than anyone with paper records ever was able to capture. And what's very convenient about this data is it just exists. It's out there. It was generated not for research purposes, but as part of routine clinical practice. And real-world evidence as a sort of means of evidence generation tries to build off that data as it actually was delivered. So this data was not generated for research. Typically, it's generated for clinical care and also for payment, which is another huge source of electronic data. It reflects actual patients broadly because it literally is actual patients treated broadly within a healthcare system. With the now incredibly large samples available through electronic health records, it allows for very large samples to be created. All sorts of case series and case records can be applied across treatment settings, particularly in larger multi-site health centers. But it is subject to the same range of biases as any other observational data. So again, if we have 90% of our patients smoking and we dutifully document that, we've got to be looking for the signal for that 10% who don't smoke versus the 90% who do. So just because we do things in a certain way doesn't necessarily mean that we ought to do it that way. But by beginning to describe on large scale what care actually looks like, it allows us to make hypothesis generating tests about what we might want to modulate and what we might want to change, and also can provide some normative data. So this patient in front of me who has catatonia, who was receiving 18 milligrams a day of lorazepam, is that normal? Is that rare? Is that unusual? What does that look like in treatment settings? And what might patients like this look like if we wanted to analyze their data? So for the rest of the afternoon, I want to present some real-world evidence data from a variety of clinical sources and describe how we've been able to try to learn from that real-world data and apply that to patients that we see in real life. So let's look at ECT in clinical populations first. So as a reminder, and the residents saw these slides when I lectured, I believe it was last year on it, ECT is a technique that provides electricity. It is not a medicine, which comes with its own pros and cons. One of the things I like telling families when I do ECT consults is the fact that you've had 7 medicines that doesn't work. Well, you never actually tried applying electricity. We have no idea if it'll work or not work, but the medications are just on a fundamentally different mechanism. And ECT itself, the original ECT devices just plugged into the wall. The electricity when you plug into the wall gets you this sort of sine wave chart that we see. That's just what it looks like in electrical outlets. We've modulated ECT now to change the parameters of it. So instead of having that sine wave, we have this square wave. We have a pulse up, a break, pulse down, a break, pulse up, a break, and so on and so forth. And the advantage of that is it allows us as ECT physicians to tune the parameters that we apply. How wide is the pulse? How many pulses are we doing? What's the frequency of those? What's the amplitude of all of it? And that's something your friendly ECT doctor is going to be thinking about as they provide treatments, because any of these 3 pulses that we describe here actually have the same area under the curve. It's the same amount of electricity, the same number of electrons that are being delivered. But these 3 have very different clinical properties. Moreover, it's not just the electrical parameters that can change, but also the location of stimulation. So when we do ECT, we're determining where we place the electrodes on a patient's head. And that affects the brain tissue that can be stimulated by blood. So here, bilateral, bifrontal, and right unilateral are the 3 most common electrical parameters for ECT. Now, this is an electrical field model, so not general data. It's actually quite hard to measure this data in vivo, but this model looks at a scalp and bone and CSF and brain tissue and attempts to quantify the electrical field applied during the ECT stimulus, depending on the pulse parameters. And as we go further down, any tissue that is in red is tissue that is more stimulated electrically. Tissues that are in the more teal color are relatively spared from the electrical field. So the original ECT parameters were bilateral, which you see here on the left, and essentially we stimulate most of the brain. The entire frontal lobes, importantly the hippocampus, all of that is directly touched by the electrical field. If we move our electrodes a little bit anterior to a bifrontal delivery, now notably this is not right above the eyes because that would hit the frontal sinus and electricity doesn't conduct very well through air, but if we keep it a little bit lateral to that, we see we can relatively spare the hippocampus, the site of memory here, particularly the left hippocampus, compared to the bilateral parameters. Yeah, obviously we're still hitting it, but we're doing somewhat less so. And that matches with clinical results that bifrontal is a little bit more gentle memory-wise. We can also shift all the way to the right side of the head. So right unilateral ECT looks an awful lot like bilateral for the right side of the brain. So we're similarly stimulating most of the frontal, most of the right hippocampus, most of the right temporal lobe, but we're relatively sparing the left temporal lobe. And likewise, this is correlated with better memory effects. So ECT, while being a broadly non-focal technique, we're stimulating a lot of brain, is not binary. It's not you get ECT or you don't get ECT. It's a lot of parameters that can be affected and changed, and which may or may not affect clinical efficacy. So I mentioned I'd be talking about off-label and on-label ECT. So just as a brief aside, I want to talk about the FDA classification for ECT. So ECT was first used in 1938 and came to the US by the early 1940s. So it actually predates the FDA's authority for regulating medical devices. So the FDA only eventually got around to classifying ECT machines in 2018. The specific classification, ECT devices are now listed as Class 2, meaning moderate risk for the treatment of depression or catatonia, for patients who are 13 or older, who are treatment resistant, or who require a rapid response due to severity of condition. Which means unipolar, bipolar, schizoaffective depression, any of those things. If you have a depressed patient who's 13 years or older, ECT is an indicated on-label treatment for those patients. Now, much like with drugs, where of course we are free to prescribe off-label, that's true for ECT treatments as well. And many of the uses for ECT, things like mania, refractory psychosis, neuroleptic malignant syndrome, or in fact maintenance ECT itself, are all off-label, strictly speaking, uses of ECT. So with that in mind, let's look at some of those on and off-label treatments and see how real-world evidence might inform the efficacy of those treatments. So this was done using a series of relatively big data sources for ECT that we were able to compile over at Mass General Brigham System. And the hardest part of this was actually collating the data sources. We got EPIC at Mass General in 2017 for the psych hospital, 2015 for the general hospital. So prior to that, data was on a real hodgepodge of sources. Since 2015, it's actually quite machine readable. It's quite easy. But this included even things like paper records that we're including before then. So the hardest part of this project was actually compiling these records into a unified data source and trying to capture those disparate sources into the most unified way possible. And what that allowed us to do was to build a gigantic data set of ECT as it was actually delivered in the real world. So for example, this is an analysis of almost 3,700 patients with almost 33,000 ECT treatments, looking at acute ECT, the first 12 treatments. And we're looking specifically at seizure duration. The very easiest thing to measure in ECT is how long does the patient have a seizure for. It's something that's been measured since at least the 1940s within data sets. And there have been various clinical observations around this, but we actually got to put numbers on some of this. So as we see, the average duration of a seizure, shown here on the left, decreases over the course of treatment. And in particular, the longest seizure is the first, then the second, and then the third, and then there's somewhat of a slowing thereafter. And one of the clinical observations that happens sometimes is that over the course of ECT, someone might have a seizure that gets too short. It's decided typically under 20 to 30 seconds is viewed as too short by most ECT doctors. And the obvious intuitive answer is add more energy, right? If we're having a short seizure, let's hit the brain a little bit harder. But on the right, we can see that actually the opposite of that would be correct. So if we look at graphing the prior seizure duration on the X versus the current seizure duration on the Y, we find that there is a trend towards decreasing seizures over the course of treatment. But if we increase the charge of electricity, the blue line here on the right, we actually find that we hasten that trend. We make the seizures even shorter on average versus keeping the energy slower or keeping it stable. So the intuitive sense of patients and then of providers for many decades proves out to not bear out within the data. More energy doesn't necessarily mean a longer seizure. Now, it may result in different clinical efficacy. That's a separate challenge entirely. But it was only when we started capturing very large data sets could we see these sorts of trends and really compute them in a broad way and allow us to question some of the wisdom that had been present in the field for decades. Again, shorter seizures with increased energy versus the opposite. We can also look at real-world treatment efficacy. Now, ECT has had a few prospective randomized clinical trials, particularly the CORE and PRIDE trials done in the 2000s and 2010s. CORE in patients generally, PRIDE in adult geriatric patients using right unilateral ECT. But one of the questions we always have is how well does this treatment work in real-world use, in actual hands, not in the rarefied environment of clinical trials? So we were able to build a very large data set of nearly 1,700 real-world patients receiving ECT as part of routine care. Our inclusion criteria were really simple. You were getting ECT, and we had a scale at baseline and at least 1 point following treatment. Everything else was fair game. All sorts of diagnoses, medications, comorbidities, inpatient, outpatient, race, gender, sex, age, the whole works. Everything was included within it broadly. Depression was measured using the QIDS, a 16-item self-report scale. This was the same scale that was used, for example, in the STAR-D trial to look at antidepressant efficacy. And at baseline, patients were coming in with a treatment severity of 17 plus or minus 5. So that's a very severe range of depression. And after treatment number 10, so we typically deliver ECT 3 times a week. So this is a little bit more than 3 weeks later, patients are leaving with a very significant improvement to about 10 plus or minus 5 on their major depression. So that's an effect size of more than 1. Again, a more than 1 standard deviation improvement in treatment on average over a time scale of just 3 weeks. Or as I describe it to families, coming in from very severely depressed to in the mild to moderate range of depression, a really life-changing amount of improvement for many patients, again, across broad inclusion criteria. You can see these black spots are broad, however. We have patients who leave ECT with a QIDS score of 26, about as high as you can possibly get on the scale. And we have some in complete remission with scores of 0. So there's a wide range of what is normative data as a result of this. Then we can look at depression response. Specifically, response is typically defined in antidepressant trials as a 50% reduction in treatment. So let's track that sort of binary outcome. So if we go from baseline to treatment number 5, about a third of patients already are reaching a 50% response rate in depression. Again, this is over the course of less than 2 weeks because we're treating 3 times a week. So 50% reduction in symptoms in a third of patients in under 2 weeks. There's nothing like it in any other area of psychiatry besides ECT that could provide that response. Maybe ketamine, jury's still out, but ECT very, very effective here. If we don't just stop after 5, if we keep going, we can get about another quarter of patients better for a cumulative response in real-world settings of 56%. Now, this is lower than what we're seeing in prospective clinical trials, for typically in the 60 to 70% range. But again, this is real-world conditions, not the rarefied environment of clinical trials, where we actually will have some diagnostic uncertainty. We'll include comorbidities and other things here. Now, 50% may or may not sound very impressive to you, depending on your base rate on these, but let's compare that to STAR-D, the prospective large real-world effectiveness trial funded by NIH in the early 2000s. Step 3 of STAR-D was patients who had already failed 2 trials of antidepressants or evidence-based psychotherapy. What was a third trial looking like? Response rate of around 15 to 17% in steps 3. And step 4 is patients who had failed 3 trials. I'll tell you anecdotally that my average patient coming into ECT has probably had at least 4 to 6 trials of antidepressant medications, typically also evidence-based psychotherapy before they come to me. So the average ECT patient would probably have failed step 4 of STAR-D. And despite that really risky and quite treatment refractory depression, we're still getting a real-world effectiveness of more than 50%. We're about 3 times better than what antidepressant or psychotherapy trials would do. So it allows us, again, to put normative data when we counsel patients of, hey, this is, if you're a gambler, this is a 3 to 4 times improved shot compared to pretty much any other trial that you would be doing. But it's very far from 100%. Again, this sort of large data in real-world settings can be extremely helpful in counseling patients of what their real-world effectiveness may be if they decide to come into treatment. What about cognition? The biggest fear we have with ECT is cognitive impairment. So there are very significant limitations of how we can track cognitive impairment in ECT. I'd be happy to talk about that in questions. But the course assessment and what we actually used in real world was the Montreal Cognitive Assessment, the MoCA. Average ECT patient came in with a score of 26 following treatment 10. They were at 25.4. So this is a non-statistically significant decrease in functioning and way below the clinically significant range, which is about a 2-point reduction in MoCA before you see any effective changes. So on average, over the course of 10 ECT treatments, we get a very substantial response to depression with no detectable decrease in cognitive functioning in patients. Again, all in broad real-world settings. What about patients who come to ECT more than once? And this is something I find actually very interesting clinical problem that we all face in everyday practice. Very often a patient will come to us and say, look, I'm 45 now and I had a bad episode of depression in my 20s. I started on Zoloft back then and it helped and I eventually tapered off. Should I start back on sertraline? And I'll typically say, yeah, why not? I mean, it feels like an intuitive thing to be doing. Or likewise, as a child psychiatrist, I'll have families come in and say, an older sibling or a parent did very well on a particular medication. What about sticking with that medication again? And I think in broad practice, we all typically do this. But if we try to find the evidence base for that statement, it just isn't there. You can look as hard as you want, and I have not been able to find any compelling data on multiple courses of depression across the lifespan. So I was interested in seeing that within the ECT context specifically. So with our large data set of, again, the 1,700 we started with, we found 153 patients who had 2 separate ECT courses. So what did a separate ECT course mean? We wanted these separated by about a year for it to be a new treatment. They had to have gone through a course of ECT, stopped for a while, and then came back to ECT. And interestingly for these patients, on the left, we are graphing correlations between the initial severity and the finals, the first and second courses. So essentially, it's very, very highly correlated. Patients come in with roughly equivalent amount of depression a second time they're coming to ECT compared to the first time with ECT. And if you look on group averages, how well do patients respond to ECT? On average, a first course of ECT and a second course of ECT look about the same. We look specifically after treatment 5 for this project. So numbers are a little bit less impressive than the previous numbers I said, which mostly looked at treatment 10. But about a 6-ish point gain and improvement over the course of 5 treatments was consistent between the 2 courses. So looking at the course group data, you might say, wow, ECT is about as effective between first and second courses. And on average, I think that is true. But when we space down to individual patients, this is where I think the interesting finding comes. So if we look at how well a patient did in their first course of ECT on the X, compared to how they did on the second course of ECT on the Y, what we're finding is essentially a random number generator. So an individual patient's response to a first course of ECT was not correlated with that unique individual's response in treatment 2. Again, the baseline depression severity was, the group improvement in ECT was, but let's look over here, some patients who were, pretty good ECT responders overall. We had a 20-point improvement in QIDS in a first course. On the second course of ECT, only a 10-point change. This patient here had no change in their QIDS in the first one and got worse with the second course of ECT. This one had a 15-point improvement with it. So when we looked on the individual patient average, we simply could not see a correlation between the first and second courses. So what's the practical implication of this? I typically will now counsel patients and say, on average, ECT works as well a second time as it does, but there's a wide variability. So unfortunately, because you were a super responder to ECT a first time does not necessarily mean that you'll be a super responder a second time. But conversely, if you take a patient who failed ECT in a previous course of illness where the treatment was not overall effective, and you are now in a discrete episode of depression, perhaps months or years down the line, you should consider whether or not ECT may be effective a second time. Regression to the mean is very powerful. So if someone had a below average ECT response the first time, they might well return to a more average response to a second treatment. Given how good the average response is, I think it's worth a try for some of these patients. So again, with a very severe depression, consider ECT for that very severe depression is essentially the conclusion. Regardless of whether or not ECT was previously successful, it should at least be within the conversation because, again, there's a wide range of response for patients who come back multiple times for treatment. What about maintenance ECT? So I mentioned that maintenance ECT was not specifically FDA authorized. Maintenance ECT is ongoing ECT treatments after an initial treatment response, meaning somebody got an acute course of ECT, call it 10 treatments, and they decide to stick with us for ECT thereafter. So this paper, we looked at 100 patients, each of whom had received quite a lot of ECT, 50 or more treatments. And we continued to track their progress over the course of 50 treatments. On average, those 50 treatments took a couple of years. This is about 2 years of overall treatment on average. And at the baseline, the patients were very average compared to our overall phenomenon. So patients went from about a 16 on the quids to about a 10 after the first 10 treatments, which exactly matches the prior data in the broader data set. But as we continue graphing, there's continued improvement in depression over about the first 20 or so treatments, followed by ongoing improvement as we continue going, without any decrease in the MoCA, despite going out to up to 100 ECT treatments is where we censor the data course here. So at the end of this study period, about a third of these patients were continuing to get ECT, past even 100 treatments for 20% of the patients. Some had dropped out, mostly because of complete depression remission. And the median cognition was borderline, about 26, which is consistent with our overall population. So what does this say? Well, at least for some patients, we can find ongoing ECT that provides ongoing depression benefit over a prolonged period of time without any evidence of cognitive worsening. So despite FDA labels, I think there's very strong data that maintenance ECT can be effective. Other colleagues have looked at treatment data for maintenance ECT specifically that was disrupted by COVID, when a lot of ECT centers had to shut down because of infection control risks. And we're able to demonstrate in large epidemiologic evidence, something that's hard to do in the US, but easier in other countries, that relapse rates worsened after the dropping of maintenance ECT. So again, the real world evidence suggests that maintenance ECT is tolerable, that it's safe, and it can be very, very effective for some patients. I want to move now specifically to a child population, which is a pediatric population. I'm a child psychiatrist, as Dr. Dotson mentioned. I direct the pediatric ECT centers at Mass General Hospital and also at Boston Children's Hospital. So I wanted to look specifically at pediatric data because, at least in the Commonwealth of Massachusetts, and true in many states as well, there are pretty severe restrictions on pediatric ECT access. There's a very different legal parameters in many states, and in fact, in some states, including Texas, ECT is banned for all patients under the age of 16. So if we're going to pass things legislatively, I would hope we're doing so on the basis of good evidence that reflects medical care. And so the question I had is, could we compare younger patients, patients who are just below the legal threshold, with patients who are a little bit older and demonstrate whether or not there's some sort of inflection point in treatment response? So in this, we looked at 108 adolescent patients comparing to about 300 young adult patients. And what we found was that the treatment response of age on the x-axis versus quids response in the y was indistinguishable. 16-year-olds look no different from 20-year-olds who look no different than 30-year-olds. If you look at the left, the change in treatment response by quids, this is a near identical graph to what I showed you before with the broader population of 1,700 patients getting it. So our data in our hands suggests that adolescent patients do not respond any differently. And moreover, we know that suicide is a very common cause of death in adolescent patients and one of the key clinical problems that we face. So if you look specifically at suicidal ideation using the suicide item of the quids, this is very similar to question 9 of the PHQ-9. We found is that the average patient coming in had quite severe suicidal thinking, a level of 2 or 3 on this 4-point Likert scale. And after CCT, and again, this is over 5 or 10 treatments, we're talking 2 to 3 weeks of treatment overall, we had a significant reduction for many patients of 1 to 2 points in their quids. Now, there's a handful of folks who, of course, can get worse. That's true in all sorts of real-world data. But by the end of treatments, the number of patients not endorsing suicidal ideation went up from 12% to about 48%. So a huge improvement in suicidal thinking, which corresponds with the improvement in depression that we're seeing in adolescent populations. So on the basis of this and other data, the American Academy of Child and Adolescent Psychiatry put out a statement just last year strongly in favoring pediatric access to electroconvulsive therapy, something I'm very, very passionate about. So very happy to speak to anyone if you have pediatric cases or questions that come through. I think this is an evidence-based treatment for youth that we need to apply. ACAP agrees. Notably, the World Health Organization put out a statement saying that pediatric ECT or ECT in non-consenting patients should be banned as essentially a barbaric treatment. And I was very pleased to be a part of the author list of a joint statement by the European Psychiatric Association, the World Psychiatric Association, and the American Academy of Psychiatry, all of which basically said WHO is completely wrong with this. And in fact, our non-consenting patients, the very sickest patients, are the ones who most need ECT and can benefit from it. And ACAP is in full support of that as well. Shifting gears from ECT, I want to talk about my other clinical passion, which is catatonia, a clinical condition that was described first in 1874 and which has received remarkably little epidemiologic research. So I want to give you guys an up-to-date on some of the newer diagnostic standards for this and what treatment looks like for catatonia. So let's start with epidemiology. So how common is catatonia really was not known until the last couple of years. I pulled hospital records across the United States, but similar data has now actually come out both in the United Kingdom and Spain across large records and data sets, which are somewhat independent, converging on very, very similar numbers. So within the United States, approximately 0.04% of hospitalizations, so 4 in 10,000 hospitalizations can involve catatonia, which classifies catatonia overall as a rare disease. The standard of a rare disease in the United States is something affecting fewer than 200,000 Americans, or based off of our current population, about 60 per 100,000. Catatonia is 5 per 112,000, so less than 10% of the threshold for rare disease. So it, again, is an uncommon condition, but still also most likely underdiagnosed. The population we see a bimodal age distribution with patients in their 20s and patients in their 60s as the most common patients being diagnosed with catatonia in the United States. A male-female predominance is relatively equal. I think what's most striking here is actually a very profound racial imbalance in diagnosis. So Black patients making up nearly a third of pediatric catatonia patients and about a quarter of adult catatonia diagnoses, which is far outside of the population prevalence. Now, does this represent a true difference in disease, or does this represent disparities in diagnosis? Does this represent some other factor we haven't yet explored? Unclear to me, and I have some research trying to attack that question. But this finding of different racial dynamics of catatonia diagnosis has been reproduced in other populations, including non-US populations. So I think a very important question for us to be thinking about moving forward. In terms of diagnosis, the diagnosis of catatonia itself has changed. We currently operate under DSM-5 in the United States. ICD-11 has, which is what the rest of the world uses, and the US will probably get to in, 20 years or so, has slightly different operational criteria. DSM requires 3 out of 12 signs. Then we also have the Bush-Francis Catatonia Rating Scale. This is the most cited paper in all of catatonia, which has 23 items without a clear number defining of what catatonia is. And the whole thing is a mess. And it gets all sorts of fun words like Gegenhalten, which really barely mean anything to a psychiatrist, much less others. If you want to have the formal training on the Bush-Francis Catatonia Rating Scale, Mark Olam at the University of Rochester has a massive, basically 20-something page PDF describing the best way to do it. And what I would argue is if we require a 20-page PDF to use a clinical rating scale, it's probably not a very useful clinical rating scale. What we really want is something like the PHQ-2 that a primary care provider or a general psychiatrist can apply very easily, that's going to provide a more accurate or at least a sensitive diagnosis that we can then follow up with more specialist data. So the question I and collaborators had was, could we do this with catatonia? Is there a way to simplify these strong, complicated diagnostic criteria to something that's operationalizable? And so we generated a screener called the Catatonia Quick Screener, or CQS. And the system looked like this. We had a cohort of 446 patients, roughly equal between adult and children across Vanderbilt and the Mass General Brigham system. These patients all scored positive for catatonia using the full Bush-Francis Catatonia Rating Scale, so the 23 items. And the question was, do we need all 23? Is there any way for us to combine items in a smaller format that may be containing many of the sensitivity of other items? So if we think about it, looking specifically at the catatonia screener, the Bush-Francis Catatonia screening instrument is the first 14 items of the BFCRS. Typically, a patient will need 2 items on the screener to be a positive screen before they move over. That, again, requires the assessment of 14 items. So if we look at combinations, there's obviously 14 ways to have 14 items. You could just have each one. That's simple. If we combine into 2, we have 14 times 13, or 91 combinations. For 3, it's 14 times 13 times 12, 361 combinations, and so on and so forth. So in total, there are 16,382 possible ways to combine the 14 items of the Bush-Francis Catatonia screening instrument. So we generated a screener using this 446 patient cohort, and then validated it using a separate cohort of almost 1,500 patients from my colleague Jonathan Rogers at King's College in London, who had a parallel data set. So looking at the CQS, what is the frequency of individual items that are being endorsed? And what we see is that they're not equal. Some of these items are actually quite rare. Mannerisms is very infrequently scored among patients, but some are quite common. So staring, mutism, and mobility kind of go together. And if we look at individual graphs, which I don't have in this data, but can show it differently, what we find is that many of the items actually are strongly correlated within each other, which means from sort of formal item response theory perspective is that there's redundancy here. We don't actually need to assess each of these items to be able to accurately look. And then when we look within pediatrics specifically, again, I'm a child psychiatrist, so I like to show you if we break down among patients with medical catatonia, all catatonia, and their developmental disorders, likewise, there are important differences. Patients with what's called medical catatonia are associated with delirium, autoimmune encephalitis, infection, inflammation, the other sorts of things, have certain items that are different. That's the orange. Patients with neurodevelopmental disorders have certain items are different. But the broad theme that there is redundancy within the Bush-Francis absolutely holds. So using every possible combination of signs, we began to reduce. When we looked for sensitivity, meaning what fraction of patients from full BFCI would be detected using these reduced numbers of items. If we look at just one item at all, we could take the most common item, which from the previous graph we see is staring. So if literally we asked ourselves one question, is the patient staring? And the answer is no, they have a 78% sensitivity for detecting catatonia. Honestly, that's not terrible, but we know we can do better. If we add a second sign, we can bring it up to 88%. With 3 signs, we get to 95. With 4, 97. And then 5 or more, we essentially have perfect sensitivity, meaning, again, there's a great deal of redundancy within the items of the Bush-Francis. With a group of experts consensus, we then put together as to what would the optimal items be, and we proposed this one, the Catatonia Quick Screener. So this is a 4-item rating scale, and the items are excitement, muteness, staring, and posturing. So if any one of those 4 items is present, we have a 97% sensitivity for detecting catatonia. Don't even need to think about the other 10 items of the Bush-Francis screening. Importantly for me, it was equally sensitive in adults and pediatric patients, so it can work across the lifespan. When we looked in terms of validating this in the London data set, we retained greater than 90% sensitivity, despite working on an entirely parallel data set with very different data limitations. We then, more recently in unpublished data, have validated this in the original Bush-Francis catatonia cohort. So Andy Francis, now at Penn State University, had on a yellow legal pad the raw data for his 1996 Bush-Francis catatonia rating scale paper. That paper is derived off of 215 consecutive admissions to inpatient psychiatry at Stony Brook, of whom 15 had features of catatonia, 8 with 1 catatonic feature and 15 with 2 or more. The raw data is there on the right. If instead of the Bush-Francis catatonia screening implement, we applied the CQS, we had 100% sensitivity, so identical to the screening instrument. Our sensitivity was no worse than 96%, and 96% is very conservative. That's assuming that all 8 of the patients with a single feature had one of the CQS features. And in reality, we don't know that. That piece of data is lost to the sands of time on paper record somewhere. We had a positive predictive value of about 2/3 and a negative predictive value of 100%. So again, going back to our items of the Catatonia Quick Screen, excitement, muteness, staring, and posturing, if none of those items is present, it is extremely unlikely that the patient will have catatonia. Of course, if your clinical submission remains really, really high for it, feel free to do a full catatonia rating scale. But as a screening feature, what we like about this and why we picked these items is you can explain all of these terms very, very easily. There had also been a prospective study of psychiatry trainees done by Oldham and colleagues looking at a standard video exam and looking at psychiatry residents and attendings. How often do we identify certain features of catatonia, some of which are pretty hard to pick up? But these 4 are pretty reliable, and you can actually do them from across the door without a physical exam, without requiring a patient to say, stick out your tongue so I can, stick a pin in it, one of those items that I've never found especially useful. And it turns out it's probably not especially useful either. Right? Some of these more objective markers that we can see from across the room come through. So we have a data validation project going on now at Mass General, looking at every single patient within the inpatient consult service to see whether the CQS can add value as a routine screener to our patients. Should have results in the next 6 months or so with it. But my hope is that we can abandon some of the esoteric terms that the Bush-Francis catatonia screening instrument is, do something like CQS as a first-line screener. If positive, of course, we'd have to follow up with a more detailed examination. But my hope is that this makes catatonia diagnosis a lot simpler for non-specialist providers. But what other ways can we think about diagnosis of catatonia? So there was an interesting meta-analysis published in 2023 of 12 studies over 308 patients, saying that abnormal EEGs could predict a, quote, medical cause of catatonia. So again, that's not a classic catatonic schizophrenic patient. This is someone with, say, autoimmune encephalitis who picks up catatonia features. And that seemed a little suspicious to me and to some of my collaborators. So we built up our own retrospective data set using more detailed examination of the EEG. Ultimately, 178 patients between Vanderbilt and Mass General and Brigham. Our inclusion criteria was they must have an EEG and a full catatonia rating scale within 24 hours for each other. We wanted to correlate that EEG along with the catatonia. Likewise, we assessed each of those patients for delirium using a validated retrospective technique called ChartDel. It's done by Nuye over at Harvard and has been able to assess, again, with a very good sensitivity and inter-rater reliability as to whether delirium was assessed for in prior patients. Among these 178 patients, 34 did not have catatonia on the basis of syllabus Francis, 82 had catatonia without delirium, and 62 had catatonia with delirium. So let's pull up those EEG features. And this is a bit of a busy slide, and I want to talk you through it. So on the x-axis here, we have the number of catatonic signs that are present, broken down into basket categories. The 0 to 3 did not have catatonia, 4 or more did. In blue, so all these shaded boxes over here are patients who screened positive for delirium using ChartDel, likewise over here and over here. The filled-in boxes means an EEG feature is present, for example, over here. The empty boxes means that EEG feature was not present. So if you kind of squint and hallucinate, it kind of looks a little bit more like there are fewer boxes filled in these patients, maybe more boxes filled in over here. That's predominantly any EEG abnormality, most typically related to slowing. So slowing of the background in EEG more recently has come out as a fairly sensitive measure for delirium. Essentially, most delirious patients will have a slowed EEG background, something that will be commented on by the epileptologist as they're reading the EEG. There are a couple of odder features that have come through, but interestingly, none of these patients actually had true seizure activity that was coming through. One with some focal seizures that were known for a patient in a history of epilepsy, but other than that, pretty uninspiring. But not terribly compelling to us. And we then actually looked at predictors, and this is using something AIPW, an augmented inverse probability weighting. It's a machine learning method. It's basically just fancy logistic regression. Details are not important. What we found is that an abnormal EEG was strongly predicted by the presence of delirium, but not as much by catatonia. Now, the error bars for catatonia are wide, so we cannot exclude a real effect there. We need a bigger sample size. But essentially, when we control for some of these baseline characteristics, what we found is that an abnormal EEG did not predict catatonia caused by a medical condition, but rather an abnormal EEG predicted delirium. And delirium itself is highly correlated with medical disorders in and of itself. So another example where this meta-analysis, working on mostly case reports that have been previously published, I think buried and missed the ultimate conclusion because the data set was too small. When we really went to a finer grained description of these patients and looked for other conditions, that finding did not hold. So do I get EEGs routinely for catatonic folks? Yeah, I do not. I don't think it actually adds to the clinical diagnosis they're in. It may help you look for other comorbid conditions as well. And if you're on the consult service and you don't think it's catatonia, you think delirium better explains it, if you get an EEG and you show background slowing, sometimes it's easier to point to the medical teams and say, hey, here's further evidence of delirium, not catatonia. But sadly, this did not work as a functional biomarker for identifying subtypes of catatonia. And the last story I want to tell today has to do with hospitalizations for catatonia, specifically looking within the pediatric context. So this is using a similar data set, retroactive, as we did before. This is at Vanderbilt and Mass General Brigham, looking at patients 18 and younger, and treated in the medical hospital over a 5-year period. We looked at patients who were diagnosed with catatonia and who had an initial Bush-Francis at time of diagnosis. Bush-Francis was the standard catatonia rating scale at both hospitals during the study period. This ultimately led to a data set of 165 individuals, about half of whom had a baseline neurodevelopmental disorder of some kind. We then extracted demographics, neurodevelopmental status, the treatments, clinical outcomes, and something called the CGI, the Clinical Global Impression, retrospectively. This is a 7-point scale going from 1 patient all the way better to 7 all the way worse, with 4 being no change. It's remarkably correlated with more detailed rating scales, and it's actually acceptable to FDA for certain clinical trials as a global statement. Again, asking you, is your patient better or worse? And you're saying, yeah, they're much better. That'd be a 2. Very much better typically means remission would be a 1. And the converse would be as well. Very much worse would be a, much worse is a 6, and very much worse is a 7. So results, looking at these patients, almost everybody got a benzodiazepine. But ultimately, the patients on the whole had relatively lower doses of benzodiazepines than we maybe had anticipated. So the highest 24-hour dose of benzodiazepine was 6 milligrams on average. So typically 2 milligrams 3 times a day was the most common dosing, sometimes 1.5 every 6 hours. That was identical for patients with neurodevelopmental disorders and without neurodevelopmental disorders. At the time of discharge, we were able to have that benzodiazepine dose to about a 3 milligram daily discharge dose. Patients were in the medical hospital for a relatively short amount of time, only about 5 days. But the total length of stay, considering medical and psychiatric hospitalization, because many of these patients would go on to psychiatry afterwards, was longer, so more 10-ish days. ECT was received in about 15% of patients, and about 40% were psychiatrically hospitalized overall. At the end of this whole period, fortunately, the vast majority of patients were able to discharge home, which speaks to the treatable nature of catatonia overall. And at the time of discharge, the Bush-Francis score was down to 4 on average for patients. But these broad numbers, I think, hide some interesting smaller data here. So first, if we look at patients for whom we have an admission and a discharge Bush-Francis, our doctors were not great at diagnosing a discharge score. What we see is overall, this reduces to 103 down from the 168 that we previously described. Admission Bush-Francis severity was around 16 on average. Discharge was down to 5, so very good improvement. But we still see some patients with relatively high humps of a Bush-Francis at discharge, but the overall trend from admission to discharge was that a significant improvement. When we dial down even more narrow here, though, let's look at patients with their duration of hospitalization on X versus index Bush-Francis on Y. What we see here is, again, a random number generator. So there's really no correlation between index Bush-Francis catatonia rating scale and total length of stay in the hospital. So one way I think we could argue this is that the Bush-Francis probably does not truly capture severity of catatonia, or at least severity in patient-meaningful ways, like total time in the hospital. I believe it captures something, but I don't think the idea that a Bush-Francis of 23 is worse than a Bush-Francis of 10 is actually proven. So I think the question of how we should best categorize catatonia, to best figure out what is worse catatonia, has to be more than the score. But more meaningful for me as a child psychiatrist is looking at these hospitalizations for neurotypical versus neurodevelopmental patients. So folks with a neurodevelopmental disorder had a shorter hospital stay of about 5 days compared to neurotypical patients with an 8-day hospitalization. Of course, they're colored differently in the graph here. But then let's look at treatment outcomes. So patients with had at least 88% of patients had at least some improvement. That's a CGI of 3 or less. Patients with neurodevelopmental disorders in an adjusted model ultimately had a lower odds of response, the odds ratio of about 0.6 compared to neurotypical patients, controlling for all of the other variables here. So what does that mean? It means that our patients with neurodevelopmental disorders are being discharged quite a bit sooner. Multiple days of length of stay of hospitalization, they're being discharged sooner, but they're leaving sicker. They're less likely to get better. Now, why is that? In our environment, our best guess for this is that we simply have nowhere to put these patients. They wind up on inpatient medicine, typically their pediatrics floor, where they're not receiving behavioral analyst treatment. They're typically not receiving subspecialist nursing care. They're being trapped in their room for the whole time, asked not to go through. They get sick. They have high rates of restraint. They have high rates of behavioral complications here. And ultimately, we're left saying to the families, take your kid home. I don't have anywhere to discharge them to. There's not a unit that will accept your child because of their baseline behavioral needs. And I would argue that this is a really huge disparity, something that we really need to be thinking about as a way to better improve care. And this is coming out of quaternary care academic hospitals, Mass General and Vanderbilt, and we have a long way to go. So I think that's true for many places, but really thinking about from a disparities angle, are we really able to serve all of our sickest patients, which in my mind needs to include patients of all age ranges and even folks with severe neurodevelopmental disorders who have significant needs for ongoing care, typically in specialist settings that we should be able to provide to them. So what we're left with in closing then is that large-scale clinical data, in my mind, helps us inform clinical questions. We can use data as we're captured, and we're using data that's better captured now than ever before through electronic health records to ask questions, particularly about even things like rare diseases like catatonia or relatively rare procedures such as ECT. We demonstrate with this data that ECT is effective in patients across the lifespan. So anyone seeing younger patients, if you would be comfortable sending a 25-year-old to ECT, and I would argue that you should be comfortable sending a 25-year-old with significant depression to ECT. You should think that similarly for your 16-year-olds. Again, the treatment response could be identical. There may be other reasons to not send that person, but efficacy is there and safety is there as well. So be thinking about this for all of your patients across the lifespan. We need improved tools for catatonia diagnosis. Say, consider something like the Catatonia Quick Screen when you're doing an initial assessment in the ED or CL floors is a much more rapid way of assessing for catatonia. But the biomarkers are not there yet. EEG specifically was ineffective for looking at causes of catatonia, and we have to look at others. And finally, catatonic patients improve with treatment. On average, folks get a lot better. But large disparities exist. We need ongoing research to assess for the best medication evidence for patients about hospitalization care, about when to use ECT and how to be applying ECT. And these are questions that I look forward to trying to answer with data as we move forward. And at least in the pediatric context, there's now a large multi-site study sponsored by AACAP going through about 10 hospitals. We're hoping to have a data set of about 500 pediatric catatonia patients, so much larger than the set that we provided here. Left to thank NIMH. I've gone through the entire journey with them, an R25, a T32, and I was very pleased that my K23 was funded last month after quite a long time of waiting. So my collaborators, Dr. Michael Henry, in the bottom left, runs the ECT service at Mass General and previously McLean. He got us onto electronic medical records early than many others, and this allowed us to ask some of the questions. Matt Siegel is a child psychiatrist at Tufts and Mass General. At Boston Children's, he's the director and my supervisor over at Boston Children's, and Josh Smith, the director of child and adolescent psychiatry, former ECT director at Vanderbilt University, and my closest research collaborator on these questions. With that, left some time for questions, and I look forward to hearing from you all.
Thank you, Dr. Luccarelli. If anybody has a question, please raise your hand and I'll bring you the microphone. Anybody viewing online, just put your question into the Q&A section and we will read it aloud. Questions from anybody? Yes, we have a question.
Could you tell us about the availability and the affordability of ECT? Is it improving?
Almost two separate questions. The affordability, yes. So ECT, the people in the world who best know that ECT works are insurance actuaries. Almost no commercial insurance requires a prior authorization for ECT, unlike many of the medications we use. And likewise, Medicare reimbursement has actually gone up for ECT recently. So it's almost $1,000 per treatment just from Medicare, including mostly the facility fee. So that part is there. Access can be challenging, particularly for younger patients and particularly in states with restrictive laws. One of the biggest challenges to ECT is that under Medicare regulations, ECT cannot be done in the ambulatory surgical setting. It must be done in the general hospital environment. And obviously, general hospital beds are expensive. So ECT, therefore, has to compete against Botox and knee replacements and other kind of high value payments for hospital systems. So I think that would be the biggest change that I can think of to improve ECT access would be removing the ambulatory surgical restrictions on ECT. But I think ECT is and typically can be profitable. We opened a new service at Boston Children's and we are absolutely in the black on numbers. At $1,000 a treatment for a treatment that takes about 15 minutes, it's hard to lose money on ECT. So if it's not something you guys already offer in hospitals around, I'd encourage you to be thinking about it. The hardest step is typically getting anesthesia access, but we think it reduces hospital length of stay. There's good data the ECT reduces overall mortality. And for those reasons, insurance companies are actually usually fully willing to cover that procedure because they know it works and shows up in their actuary data.
Thank you. Any other questions? Do we have anything online, Jennifer? Oh, we have a question right here.
Hi, my name's Haley Silverstein. I'm a PGY3 psych resident here. I love ECT and I want to get more of my patients to do it, but I have this hurdle of when I bring it up to them, I'm like, okay, I got a great option, ECT, and they're like, what is it? And then they're like, oh my God, it's the one who flew over the cuckoo's nest. And I feel like I have like an uphill battle trying to get buy-in from them or have them see what ECT is now compared to what it has been portrayed to be. So how do you kind of approach those discussions?
So part of the easy thing is by the time they enter my office as an ECT doctor, they're willing to talk about it. So that's a little bit of a cheat that the barrier comes through. I think a lot of this comes from you as the referring doctors and that relationship you've built with the family. So I think it's fair to bring up, I would typically bring it up in the context of treatment options. Usually I'm thinking about neuromodulation generally, either after the patient's, call it second psychiatric hospitalization or the second or third failed medication trial that they've gone through, to take an opportunity to sit back and reassess our overall treatment course and what the functioning is. And I would typically bring up a variety of options at that stage. I would typically bring an ECT with the conversation. If again, assuming the patient you think has some time, they're not critically ill. If they're critically ill and you're thinking about admitting, being a little directive, I think, is okay. Like, I'm really worried about you and that you haven't eaten and you're losing weight rapidly from your severe geriatric depression. We really need to get you into treatment right now. This is the best option, and present it. But I would think it's fair to bring out things like TMS and ketamine within a similar conversation with them as a sort of broad family of techniques. I describe ECT as typically the gold standard treatment is how I describe it. And I think that that's accurate. I say it's nothing like it looks like on TV. It's the fastest way to get people better. It works very rapidly. It's done under anesthesia. And typically you're just looking to get the buy-in sometimes to get them into that next conversation with the specialty doctor who's going to be doing the ECT consult itself. To the extent that you can describe the day, I typically start off my ECT consults very practically by saying, all right, I'm sure you're coming with a lot of questions. Let me just describe what it might look like if you were getting ECT. And I literally walk them through the day. You're going to park. You're going to go up to the third floor. We're going to put an IV in. We're going to put an oxygen mask on. Medicine is going to come through your anesthesia. You're going to be totally asleep. You won't see anything. You won't feel anything. While you're asleep, we apply electricity. The total duration of anesthesia is about 10 minutes. Afterwards, you get up and go home. Most patients are out the door in under an hour. You know, I got a more detailed speech than that, but that's typically how I look through the practical questions with it. And the key thing I hit for folks is that, boy, this works really, really rapidly and effectively, and that there are other options, and I think it's always worth presenting within other options. I think for the moderately ill patient, TMS is a really great option if you're able to get access and insurance coverage for it. I think ketamine, the jury is out. There's a lot to be thinking about that as a treatment. But I think you as the referring doctor, if you are confident in referring and describing it to patients, goes a huge way towards getting that buy-in to come into the door originally. I'm also a big fan of measurement-based care, so capturing routine measurement-based care is the part of it. Sometimes it's nice to be able to pull up numbers and say, boy, you know, we've been together for 6 months, and in that 6 months, we've tried 3 different medications here, and I'm worried that your depression hasn't really gotten better because you're still not working and you're still struggling, and you know, these pen and paper things I make you fill out everywhere haven't really improved here. Are you interested in hearing about other options that might be more effective? And then I would present it there. But I agree, stigma is a huge problem with ECT. Probably about 100,000 Americans get ECT a year, and many people don't talk about it. And a very common story I've heard from patients is once they start ECT and they mention it to someone, they find out that their own family member, a relative, a neighbor, someone like that has also gotten it, and they just never knew it about in the first place. So I think I'm really glad that patients are starting to speak up more and more about this. The conversation is happening. There's a ECT and Catatonia Facebook group that ECT and autism Facebook group that they don't let doctors on, but again, families are finding each other on this. And I think that kind of narrative is really what's going to shift the conversation, but it's going to take some time.
Thank you so much for your presentation. Thank you everybody for being here, and have a great day, everybody.